So as we get started, I'm going to move us into the first panel, which, as I mentioned, looks at the lessons learned from strategic policy planning, looking at modeling and what it did and did not accomplish, and how countries approached planning around the COVID epidemic. I'm going to introduce all of the panelists at the outset, and then we'll turn to them sequentially for their presentations. First, you'll hear from Mark Chitt, as I mentioned, one of the theme issue advisors, a professor of vaccine epidemiology and head of the Department of Infectious Disease, Epidemiology and Dynamics, and co-director for the Global Health Economics Center at the London School of Hygiene and Tropical Medicine. You'll hear from Adolfo Luis Rubinstein, founder and general director of the Institute for Clinical Effectiveness and Health Policy. Sei Lim, postdoctoral research fellow at the Harvard T.H. Chan School of Public Health. Pedro Bernal Lara, a health economist at the Interamerican Development Bank. And Cristian Herrera, a senior health specialist in the Latin America and Caribbean region at the World Bank. So as I say, I'll turn to each of our presenters sequentially. They'll run through the papers that are included in the issue, and then we'll have some time for question and answer. Mark, with thanks for all you did to make this issue possible, I'll turn it first over to you.
Great. Thank you very much for the introduction and the kind words. And I'm really delighted to be able to kick off this really exciting webinar. And I'm delighted because I can start off by talking about modeling. So, I mean, epidemiological modeling has been used to understand infectious diseases and pandemics for a long time, but I think it really entered the public consciousness during the COVID-19 pandemic. And so the work I'm going to present is really asking, well, to what extent did it help and to what extent didn't it? And was there anything we could learn from this? And really the lessons we're going to learn, I'm going to draw together from, if we can go on to the next slide, from two consortia of modeling groups across Western Europe called the EpiPost Consortium and the ESCAPE Consortium. So really this article brings together 15 authors from 9 institutions and 8 countries in Western Europe. That's the UK, Portugal, France, Belgium, the Netherlands, Switzerland, and Italy. And these were all countries which had the capacity to conduct modeling, but actually took very different approaches to modeling. And so we could, from the collective experience and from actually the different modeling groups working with the national stakeholders, but also coming together to share lessons learned, we could really find out what worked and what worked less well. And so if we go on to the next slide, please, if we go to the next slide, please. One thing we found as we surveyed the different ways modeling was conducted in these countries is that there were very diverse ways to actually organize modeling, and each of them had their strengths and weaknesses. I mean, in the Belgium and in the UK, there was the what's called a modeling consortium approach. I mean, one possibly well-known group is SPI-M in the UK, for instance, which brought together about 10 different modeling groups across the country, each of which independently modeled the COVID-19 pandemic based on questions raised by government, and then came together to reach a consensus to be used to advise the government. A similar picture in Belgium, although with slightly fewer groups. But then others had an expert committee approach where they invited modelers to be part of a wider committee that included maybe epidemiologists, virologists, ethicists, and so forth, to actually directly help to inform, well, to provide evidence to the Ministry of Health or the government. And then the Netherlands took a third approach, which was actually the National Public Health Agency itself conducted the authoritative modeling for the Ministry of Health. And so there were these diverse ways to organize modeling, but actually each of them worked or had strengths and weaknesses, but actually the lessons we learned from them, I'm just going to summarize a few key lessons on the next slide, please. One of them is, well, everyone agreed the next pandemic will be different. There's no point going through the exact same playbook we went with COVID. The next pandemic could be not even a respiratory disease. It could not be a coronavirus. So we've got to be prepared, but not prepared for only exactly the same thing. All the groups, as well as policymakers who worked with them, realized the importance of timely access to data for the modelers to be able to come up with results at the sort of pace that policymakers needed them. The advantage of collaborating between groups and countries, so we could learn what worked, what didn't work, what were the strengths and weaknesses of different models, of going beyond just health and realizing that economic growth, education, mental health, these are really key objectives of policymakers that also need to be considered. Closely working with not just policymakers, but also the media, and help really making sure that the public, there's good communication and engagement with the public, and actually training modelers and other scientists to really get skills beyond the traditional academic toolkit, because things like skills in media communication, for instance, became so important during this time. And one key lesson, one key quote is really the point that traditional academic structures in academia do need to be reformed so that they appropriately recognize these contributions to things like advising policy making and public communication, not just producing the papers, producing the science, that's incredibly important, but also using it in order to support the rest of society as much as possible, whenever possible. So that's from me. Looking forward to the Q&A after this.
Wonderful. Thank you for kicking us off. I'll now turn to Adolfo Luis Rubinstein.
Well, thank you, Alan. Thanks, Health Affairs, for this opportunity to present our study, which is Lives versus Livelihoods, an epidemiological, social, and economic impact of COVID-19 in selected Latin America and Caribbean countries. Next, please. As you probably know, our region was one of the regions with the highest COVID-19 related death toll worldwide. And this happened despite, in most of the countries, stringent mobility restrictions that in turn trigger large economic losses. We started in 2020 with sponsorship of the IDB in our region to build a user-friendly, open source, transparent, and interactive platform to inform policy decisions on the mobility restrictions and the public health and social measures in order to evaluate and assess the preparedness and response of health systems in our region. And this was before the vaccines in 2020. We progressed to another model, taking into account the vaccination uptake and rollout in all the countries. And finally, we started to build an integrated model where we could evaluate the impact of epidemiological, economic, and social impact of the mobility restriction measures that were adopted in Latin America and the Caribbean countries. And for that, we first use a model for Argentina, my country, and then we extend the model for Brazil, Mexico, and Jamaica. And this was sponsored by WHO and then by the IDB. Next, please. Our EPI model customizes the key EPI clinical and policy parameters, and it has the advantage of allowing to modify them according to the specific pandemic trajectory, the policy context, and the vaccination strategy in each country. And the economic model quantifies the GDP loss and the poverty associated with mobility restrictions, by incorporating the interaction of the lockdown measures and other mobility restrictions with the behavior of the population. We have incorporated a concept called lockdown fatigue that is estimated as a time-varying degree of compliance with mobility measures as long as the restrictions prolong over time. The main link between the mobility restrictions and the economic impact works through the reduction in working hours. And this is the link between both models, the EPI and the economic model. And the stringency of the mobility restrictions preclude workers from getting to the workplace that effectively reduce the working hours and produce a GDP loss. Next, please. This is what happened as an example in Argentina. Look at the gap between de facto mobility, the jure mobility restrictions of the regulation, the policy measures on the one hand, and the facto mobility restrictions. as the mobility restrictions extend into, throughout the year, as you can see, the gap increases. Next, please. So the overarching aim of our study was to evaluate the epi-econ impact of COVID-19 in Argentina, Brazil, Jamaica, and Mexico through outcome measures that, such as death, the metrics were death, hospitalizations, ICU, hospitalization, so severe hospitalization on the epi side, and loss of GDP, poverty, and the distributional impact according to sex and income level of a mobility restriction that were implemented to mitigate the COVID-19 epidemic, and always taking into account the vaccination rollout. Next. This is how the integrated epi-econ model works. You can see here in light blue, mobility to the workplace was the link, and on the econ side, you can see that lengthy restrictions increase the lockdown fatigue. And as you can see, this will impact the econ model outputs. And as you can see also on the epi side, you can see the lengthy the more lengthy the restrictions, the more increase the lockdown fatigue, and reducing the working hours and increasing the GDP loss. On the epi side, the more death in a period of time, like severe disease, death, or ICU hospitalization, create a kind of fear factor that decrease lockdown fatigue. So this is the interaction, a recursive interaction between the econ model and the epi model that impact on the mobility to the workplace, which in turn impact on the GDP loss. And you can see that, of course, the GDP loss will be shaped by informality, which is very common in Latin America and the Caribbean. In some countries, it's more than 50% informality. The fiscal policies, that were implemented in each country, and the safety nets and the labor capacity. Next, please. So the lockdown fatigue is a concept that combines the psychosocial disturbances of isolation and the need to get out, but also the economic needs, the growing income needs, in particular for low socioeconomic status households and informal labor. And this negative relationship between mobility restrictions and working hours works on the decrease with the cumulative effective length of the policy measures on the one hand, but increase when there were, COVID-19 related death. And this results in a non-linear relationship that captures the gap I showed you in a previous slide between the URE and the factor intensity of mobility restriction. Next, please. This is the main results. I will just present a few results. This is a comparison of the trade-off epidemiological and economic slopes across countries. You can see here that the slope of the trade-off lines represent how much GDP a policymaker has to give up to reduce the death count, what we call a sacrifice ratio. The steeper the slope, the worse in terms of trade-off. For instance, reducing the GDP loss at the margin by 1% will increase the daily death count by 0.5 per million in Argentina, but only 0.3 per million in Brazil. And this may reflect difference not only in the pandemic trajectory, but also in the healthcare system, the economic structure, and the fiscal response in each country. Next, please. And as you can see here, also the change in the poverty rate in the base case, base case is the actual measures that were taken by each country, and the counterfactual scenarios, but in general, relaxed scenarios of restrictions. And you can see we have data here from Argentina, Brazil, and Mexico, not from Jamaica. And the difference between the base case and the counterfactual scenario in each country widens when the stringency of policy measures is heightened. But as the years goes by and the restriction ease and the vaccination uptake increase, both lines tend to converge. Next. In conclusion, among the 4 countries, Argentina displays a higher GDP loss and a lower death count compared to Brazil and Mexico. That highlights the short-term trade-off that I mentioned before. We observe a larger income loss for women than at the beginning of the pandemic, and also a small differential income loss of lower income workers that typically are in contact with contact-heavy activities and less equipped, lower income workers, to transition to telework. And our results show that the economic impact is uneven across countries. And in addition to the pandemic trajectory, the policy measures, and the vaccination uptake that may reflect differences in the social and economic structures, as well as in the fiscal response to the pandemic. And finally, this interactive and customizable modeling platform, and the link is in the paper, can be useful to inform policymakers on the calibration of policy decisions, particularly for future pandemics. Thank you.
Thank you so much. We'll now turn to Xiyang Lim.
Right. Hi, everyone. My name is Xiyang Lim from the Harvard School of Public Health, and I'm here to talk about why similar COVID policies resulted in different COVID-19 outcomes. So in the first year or two of the pandemic, there was huge variation between countries in per capita COVID-19 death rates, over about 100 times difference. But if you consider the steps that countries took to deal with the pandemic, most countries were dealing with it in similar ways. Now, they had some combination of non-pharmaceutical interventions, could be NPIs like lockdowns, school closures, social distancing, mask mandates, and so on. So why is it that some countries ended up with far more deaths than others? And we found that many seemingly obvious factors do not explain most of this variation. So things like wealth, healthcare capacity, or even age, which matters for individual level outcomes, but not so much at community scale. Next slide, please. So what explains these differences? Next slide, please. So to resolve this puzzle, we used the simple pandemic model with one crucial modification, where we include a behavioral response whereby people take steps to reduce disease transmission in response to the perceived risk of death from COVID-19. So think about an outbreak wave. Click, please. The infection spreads and case counts start to rise, followed by hospitalizations and deaths. And as the situation worsens, eventually governments and people are going to respond by taking steps to reduce transmission. And that's going to curb disease spread, and eventually the wave subsides. Now, eventually, the memory of that threat starts to fade, the interventions are relaxed, and that's going to set the stage for the next wave to begin. So we fit a model that incorporates this behavioral response to data from over 100 countries. And what we found is that ultimately, most countries actually converge to very similar levels of response. So each ends up in this sort of dance with the disease. They take just enough steps to control transmission when it really gets out of hand, and that results in an average long-term reproduction rate of about 1. Now, crucially, the steps that are taken, like social distancing or school closures and so on, are actually very similar across different countries. And that's because everyone is dealing fundamentally with the same disease, which requires more or less the same control measures. Now, where countries differ is in how readily they actually take those steps, so how sensitive they are to the threat of COVID-19. We call this responsiveness as distinct from the response itself. So more responsive countries act faster at lower death rates, and that results in fewer deaths compared to less responsive countries, even though, and this is really important, the NPIs that each may adopt are ultimately going to be similar. And we find that countries vary widely in responsiveness, and it's actually these differences in responsiveness that explain most of the differences we see in long-term average mortality outcomes. We further found that responsiveness correlates with 2 cultural constructs, openness, novelty, and power distance, but it's not a purely cultural phenomenon. So our findings yield several important policy implications. First, they help to resolve a potential point of confusion, which is that if you look at studies of the effectiveness of various interventions, a lot of NPIs like mask wearing or social distancing, they have clear proximal benefits in reducing transmission. But if you look at studies comparing their effectiveness across countries or over longer timescales, often you see mixed or ambiguous results. Now, with our model, we can understand that that's because the long-term mortality outcomes depend less, they depend less on the specific response measures to COVID outbreaks, because after all, those measures are going to be broadly similar across most countries. And instead, long-term mortality depends more on how readily those responses are actually adopted. Second, if we look at this from a different angle, we can see that greater responsiveness to outbreak threats can save lives without necessitating much more stringent control measures. Because you cannot ignore an outbreak. One way or another, you're going to need to respond eventually, and you're going to need to adopt similar sorts of control measures in the end. But if you try to wait, if you try to put off taking action, you end up with far more people dying, and ultimately you're going to be forced to act to control it anyway. So it's better to act sooner, to act more responsively, and thereby save more lives in the long run for more or less the same level of inconvenience. Finally, some of what determines responsiveness seems to be cultural, but a lot of it isn't. And this is actually good news because deep cultural characteristics are harder to change. So this means that it should be possible for many countries to improve their responsiveness. We haven't dug into this too much in this study, but there are many ways that pandemic preparedness can likely play a role through strong public health operational infrastructure, flexible contingency planning, clear, well-established lines of communication between governments and people about public health matters, and also, of course, a built-up level of trust. These are all things that can likely improve responsiveness. And the good news is these are things that can be developed and practiced in peacetime, so to speak, so that communities are better prepared for the inevitable next pandemic. Not just in the traditional aspects of pandemic preparedness, like surveillance, outbreak surveillance, R&D pipelines, and so on, but also taking account of the critical role of responsiveness as well. Thanks for listening, and I look forward to any questions.
Excellent. Thank you so much. We'll now turn to Pedro, Bernal, Lara.
Good morning, everyone. Thanks for organizing this forum. I'm Pedro Bernal from the Interamerican Development Bank. And I'm going to share with you the findings from this paper where we analyze how disruption in healthcare services that were not related to COVID had consequences for health. And what can we learn from this in Latin America? This is John with our colleagues from the IDB. Next, please. So Latin America was hit very hard by the pandemic, although the region accounts for around 8% of the world's population. It accounted for around 30% of the global COVID death toll. And there's a lot of evidence now that there was like substantial disruption in all types of health services, preventive services, outpatient services, emergency, and even hospitalizations. And while the association or the relation between the disruption in services and health is more studied, particularly in Europe and the US, less is known about how this disruption in these types of services influence population in low and middle income countries. So our aim is to provide regional evidence in looking both at how public hospitalizations were affected and their association to mortality for conditions amenable to healthcare in 4 Latin American countries. Next, please. In our study, we focus on 4 middle-income countries from the region: Brazil, Ecuador, Peru, and Mexico. These 4 countries account for around 60% of the population in Latin America. And while their health systems are quite different, they face common challenges. For instance, they have an increasing burden of non-communicable diseases. They have fragmented health systems. There's a large participation of the public sector. Like, for instance, 65% of all hospitalizations in these countries are from public hospitals. And probably the most important challenge, while there have been important progress in terms of coverage and of access of health services, there's still relatively low quality. Some studies estimate about 70% of preventable deaths are related to low quality of care. Next, please. And what are these conditions amenable to healthcare that we focus on? Essentially, these conditions are defined as conditions for which mortality can be averted for people below 75 years old with timely and effective care. There are many lists in the literature of this. We focus on one list from the Pan-American Health Organization. And just to give you an idea of what these conditions look like, here in the table, you see, for instance, in non-communicable diseases, you see they include diseases like hypertension, diabetes, some types of cancer, appendicitis, abdominal hernias, and all maternal and neonatal conditions are considered amenable to healthcare. Next, please. Prior to the pandemic, how does this look? pretty much in our study, 64% of all hospitalizations were amenable to healthcare, and the majority of these are related to maternal and neonatal conditions. And about a third of all deaths of people younger than 74 are amenable to healthcare, and the vast majority of these for NCDs, like 7 out of 10 are NCDs. Next, please. So we use data from these 4 countries on public hospitalizations and mortality on these conditions amenable to healthcare, and we construct rates, age-standardized rates per 100,000. We use data mostly at the subnational level from 2015 to 2021, and we consider the pandemic period from March 2020 to December 2021. And essentially, we try to see how health services and mortality were changed during the pandemic period relative to the historical average, controlling for other factors. Next, please. Next, please. So what we find essentially is that we find a reduction of about 4.3 public hospitalizations jointly in these 4 countries, which is like about a reduction of 28% in hospitalizations. And at the same time, we find an increase of around 100,000 deaths for these conditions, which is an increase of around 15%. And the majority of this increase in mortality comes from non-communicable diseases. Around 90% of this increase in mortality comes from these conditions. Next, please. When we break down essentially these conditions into the different types of diseases that are included here, what we find is that there is a decrease pretty much in all types of hospitalizations, in all conditions, and it's also an increase in all types of mortality, except for those defined for children. Like you only find reductions in mortality for neonatal or communicable diseases defined for pediatric patients. And most importantly, what we find is even after we control for many factors like related to COVID vaccinations, COVID cases, the stringency, the COVID containment measures, a decrease of around 28% in public hospitalization, which is what we find is associated with an increase of a 12% in mortality for the same conditions. Next, please. And also really important is that this increase in mortality for these conditions was fairly unequal. What we find is like the poorest states in these countries have the largest increase in mortality, and there's a very clear gradient that you can see from this figure. Next, please. So what do we learn from this? So what we learn is essentially the disruption in essential health services accentuated challenges that the region already had. As a way of example, for instance, in Mexico, prior to the pandemic, like only 1 in 5 patients with hypertension were diagnosed, controlled, and treated. So it's a huge gap in care. And with the pandemic, patients with these conditions had more difficulties accessing care, like any type of care. And as a result, there's also some studies that show that there were increases on patients with uncontrolled hypertension. So since these patients with chronic conditions are really sensitive to gaps in care, there is really no surprise that there's increased mortality from some of these patients as this disruption in care occurred. Next, please. And as I said before, the biggest disruptions were for these patients with non-communicable diseases, mainly cardiovascular diseases, diabetes, and renal failure, and they account for about like 90% of the increase in mortality. Next, please. So what can we learn from all of this? I guess the main takeaway here is that during emergencies, maintaining essential health services is really important, particularly for patients with non-communicable diseases. And if this had been maintained, we have avoided many premature deaths. And the most important key lesson is what can we learn from these countries and what these countries did in terms of how to build more resilient health systems and more resilient healthcare service delivery. So first, what we learn from preparation and response, emergency planning should not just involve just addressing the specific emergency at hand, but actually how to maintain essential health services. And this involves things like identifying the high-risk patients, having governance systems that allow to manage capacity between different networks, and usually they don't communicate, like the public networks and the private networks. It's really hard for them to communicate and actually have capacity available for all types of patients. And also communication with the public is essential. In many of these countries, services were just postponed or canceled like abruptly. causing a lot of confusion and distrust in the public, and probably causing delays in care-seeking behavior as well. Next, please. During an emergency, minimizing negative consequences is essential. For this, I guess the importance of maintaining coordinated and continuous care is really important. And many of these countries experimented with alternative modalities of care, like in a limited way, but it's important to learn how can we leverage these alternative modalities of care to provide the healthcare needs, particularly for patients with chronic conditions. For instance, telemedicine was used in some countries like Peru and Brazil to monitor patients with chronic conditions. Some countries experimented also expanding options for medication delivery. In Peru, they had home delivery in medications. In Mexico, they simplified the way medications are refilled. And there's probably like a key role for non-physician health workers, nurses, community health workers in monitoring these types of patients. And of course, information systems that facilitate case management are really, really essential. Next, please. And finally, after the pandemic and the emergency, the recovery is also really important. What we found is that there's a huge reduction in preventive services, and there's a backlog in addressing this. So addressing this backlog in screenings for hypertension, diabetes, and certain cancers is really important, as otherwise we will see more health consequences down the road. And finally, like learning and adapting from what all this entailed is really important. This is probably like the biggest challenge for health systems, to have organizational structures that can actually learn from how healthcare systems fail in providing healthcare for these patients. Thank you very much.
Thank you. And our final presentation in the first panel will be from Cristian Herrera.
Yes, thank you very much, Alan. And I think my presentation will be a good complement also to Pedro's and what we have heard before in the webinar. So thank you very much. And what we did with our team in the Latin American region was to focus on routine health services, and try to understand what drove the disruption of healthcare services and how LAC countries responded. So what did they do about it? The next, please. So Pedro also mentioned, but LAC, the Latin American and Caribbean region, was really hard hit by the pandemic. One of the regions with the largest impact, in health, So only 8.5% of the population, 12% of COVID cases, 26% of all COVID-19 deaths, and also 15% of global excess deaths, excess mortality. So all more than the population in the region, but not only on health, also in education. We know school closures was dramatic in the region. And the years learning loss was 1.5, the estimation that was also calculated by the education team in the World Bank. And the economic impact was huge, 7.7% contraction of the regional GDP in 2020, the largest seen in over 100 years, and the worst worldwide was in that year. And of course, what we aim to explore with this study, disrupted health services, the same as Pedro mentioned, virtually in all areas, and for all conditions, this was disrupted. The next, please. The objective of our study was to examine from the perspective of healthcare system decision makers and managers how COVID-19 pandemic affected routine health service delivery, the barriers that they face to maintain these services, and the strategies they developed over time. And we focused on 8 Latin American and Caribbean countries. The next, please. As I said, well, this is an exploratory qualitative study. We conducted semi-structured interviews from May through December 2022. This was a purposive sample In Argentina, Chile, Colombia, Dominican Republic, Mexico, Paraguay, Peru, and Uruguay, 42 interviews were conducted in these 4 groups. So we went to look for people with responsibilities during the pandemic in public policy making, so at ministries of health, higher levels, then health services provision planning, also in ministries of health, but also in other in provincial level, regional levels. And then in the area of provision, of services, so primary healthcare and hospital management. So this is the representation across these 8 countries. And in terms of the methodology, we used, from a qualitative perspective, we conducted a thematic analysis of the data. The next, please. So the results first, very quickly, what type of services we divided this in primary healthcare and hospitals now. So follow-up of chronic conditions, mental health, screening and early disease detection, routine vaccinations, prenatal and family planning, dental care. This was some of the widely mentioned, the common mentions from interviewees from all countries. In hospitals, the same. The common were cancellation of elective services, emergency hospital procedures, and medical consultations for a specialty, all different specialties. The next, please. Then we move to barriers. What were the barriers? And we divided this from what was pre-existing. So pre-pandemic structural weaknesses that interviewees identified on the common features across these countries. So we have a basic infrastructure, that it was already weak in the region. Similarly, the health workforce, especially here in terms of numbers, of medical doctors, nurses, and others. Obsolete technology was mentioned at the same time, despite the efforts, but still a problem. And finally, low public expenditure on health. The financing for health is still, there is a big gap there, and it was identified as such. Then during the pandemic, there was a lack of funding. It's connected to everything to the pre-existing weaknesses, but lack of funding for expanding services for hiring new personnel, for purchasing medicines, personal protective equipment, and so on. Then telemedicine, of course, was a key strategy, but it still was identified as a problem in many ways. So it was a good thing, but it was problematic for them, for people who were making decisions and managing the system because of the limited capacity. Then one of the strategies that was also mentioned before, the visits home care, trying to approach services to people as much as possible, but this was rejected. So there was some fear, of course, from the population, and this example of home care rejection is one of those. And finally, misinformation and lack of trust from the population. So it's linked to what was presented before as well. The trust is a key feature that was also identified here. The next, please. And this is to give you an example, one of the quotes from one of the person we interviewed during 2020, he was saying, or she was saying, we did not receive resources to hire additional healthcare workers. So all the personnel worked everywhere. We had psychologists, dentists, nutritionists, delivering medicines in pharmacies and at home, social workers, paramedics as hosts at doors. We all function in all areas. So in practice, providers managed, and they had to innovate in some way. But the final quote, I think it's quite remarkable. We all function in all areas. So they were all trying to cope in the best way possible. The next step, please. Thank you. So then to sustain health services, one of the most important things that was the ministries of health and governments boosted its stewardship role. So they really took a handle of the pandemic. And one of the things that they did was to provide universal coverage in some way for COVID-19 patients. So this regarding the type of insurance they had, if they had insurance, they put together and coordinated public and private provision as well. So that was a big, important change in the system. They obviously reconverted the resources, in particular for hospital. They eased the regulations for hiring and retaining health personnel. Authorized the new emergency spending. There is good data of how much that increased during the years of the pandemic. The expansion of telemedicine, and the regulations for that. New strategies to case follow-up, in particular for non-communicable diseases, for example, and financing policy changes. So, for example, some countries eliminated co-payments for some services. The next, please. Then to recover, that was to sustain, but then to recover when the pandemic started to recede a bit, there was an effort to start recovering health services. So the prioritization was on preventive services and also on rescheduling postponed surgeries. Then they also tried to keep this successful policy of unifying the system, that I mentioned before, the public and private sector, disregard of the type of health insurance, and also the use of telemedicine. Mobile facilities was also continued. They tried to retain contracted health personnel. That's even an issue still for some countries, how to do that. And finally, follow-up for NCD patients in primary care was a priority. The next, please. So after that, the policies itself that were implemented had these unintended consequences, of disrupting routine health services. That's something that we know. Then the stewardship role of the Ministries of Health was critical during the pandemic. In emergency times, you need someone to really conduct and to direct and lead the response. And this happened maybe not in a very planned way, but it happened in practice in these countries. Then in the short term, the priority is to restore and improve the volume to recover these interrupted services. And then they all agree that addressing these structural issues and building resilient healthcare systems was key for future public health emergencies. The next. And I highlighted, this is the last one, the quote that the editors of Health Affairs also put in our paper. An important implicit finding of the study was that despite the recognition of the importance of primary healthcare, it was not prioritized during the pandemic. And in many ways it was underutilized. And I say this because we are now in Uruguay. And actually, I'm here now with colleagues from the IDB, with colleagues from the Pan-American Health Organization and the World Bank, launching an alliance for primary healthcare in the Americas, with this forward look intention of strengthening health systems through primary healthcare to respond to future public health emergencies through resilience. So yeah, I think it's very good that we are aligning into this in this direction to the future. So thank you very much. I think that's the last one, and let's stay in touch. Thank you.
Well, thank you all for those exceptional presentations. I could go in quite a few different directions. I'm going to start a little narrower, but to try to broaden out to some more conceptual issues around the modeling. So the last two papers were really about the effects on health system functioning outside of responding directly to the COVID pandemic as COVID. And so my first question is the degree to which, when we look at modeling done around the world, effects on the health system itself were central to those models. And I might just say that in the United States, we certainly heard a lot about load balancing and efforts to try to close gaps. But when we heard about models, they weren't mostly talking about the effects on the health system per se. So can any of you sort of weigh in on the degree to which that was even part of the thinking of many of the modelers out there or the models out there? Mark?
Yeah, sure. Maybe I can start. I think that's a great question. And I think the epidemiological models did, I think, were very important in terms of the effect on health system resources. For instance, I think actually for many policymakers, one of the key metrics was to what extent the demand on hospital resources or even intensive care resources, what extent the different policies would cause that demand, and would it exceed the supply in those areas? And so I think, I mean, I would say that was probably maybe the most important metric in some systems, not to let the health system become overwhelmed. I think where most of the models did not, partly because it was so difficult to predict in advance, but did not do so well, is looking at what effects these interventions would have on hospital demand due to non-COVID related diseases. So for instance, if there's a lockdown, if there are restrictions on movements, then, well, some kinds of sort of like health problems will reduce, like maybe road traffic accidents, but others, you know, people will have problems accessing care for things like cardiovascular diseases, and that would cause other negative effects. So I think there were some models that looked at that, but I think that was a sort of underexplored area.
Okay, well, let me broaden out the question here, and I'll just encourage you all to indicate your willingness to jump in. This is a open conversation. So when I'm not a modeler, but when I look at these papers together, I'm left with some puzzles that I'm hoping you can help me think through. One is, Mark, at the outset, you mentioned the importance of sort of interdisciplinary work and the poor incentives of the academic structure. And that would suggest the need for incorporating diverse perspectives in the modeling. There's reference to social context. We've just talked about the health sector ability to respond. But I also imagine that as you add dimensions into the model, you introduce lots of opportunities for error, for assumptions, for feedback loops, how much the economy suppresses but also increases the burden of the epidemic, how much, again, we just had this conversation about health system response. So sitting back, again, it's a very high level question, but it is one prompted by all of these papers. As we think about the lessons, although there's clearly a desire for modeling results that cut across COVID deaths, non-COVID deaths, economic consequences, the health consequences of economic consequences, the effects on health systems, do we gain by trying to predict and model all of those things? Or do we, even though we want that information, do we actually lose because our uncertainty grows and the credibility of the modeling starts to go by the wayside? It's a big question, but it is one I couldn't help but think of as I listened to this variety of presentations. Adolfo, please.
Thank you, Alan. It's a big question and very difficult to answer, but I will try to give you an example of what we did. I mean, in our trade-off, epidemiological economic trade-off models, we try to include both perspectives, the perspectives of not only from modelers, but also from the healthcare perspective in terms of the epidemiological trajectory, the saturation of hospitals, and the death and the prevalence of serious complications, with the economic downturn of the policy measures. And we try to create a model, a trade-off model, where you could calibrate the consequences of what you do. I mean, particularly if we think in a future pandemic or a future disaster like we had in the COVID era. And trying to, as I said, trying to incorporate not only, because what happened in my country and many countries in the region, two other presenters, presented what happened in our region. But in general, I would say that there are two behaviors. On the one hand, the safety focus, trying to protect and to save lives, okay? And if you try to protect lives, in our conception, what happened in our region was to prolong lockdowns and mobility restrictions and non-essential business and schools closures and etc. And there were other countries that adopted another policy of, okay, we are going to protect lives, but also livelihoods in terms of, okay, we have to calibrate what we do. I think that all of us learn by experience along the way, because many, I wouldn't say that many of the policies that we put in place along the pandemic were based on evidence or were empiric and intuitive, and I would say that all the countries fare the same, at the end of the day. So I think that we have to be prepared for the next pandemic. Hopefully we are not going to see that. Trying to see what happened when we move the lever. If we move the lever up or down, what happened in terms of the pandemic trajectory and the economic consequence, lives versus livelihoods. And I think in our case, our team, our research team was composed of, I'm an epidemiologist and a physician, I'm a family doctor, an implementation researcher, and a former policymaker, if you like. I was Ministry of Health in my country. And we had economists, we had behavioral scientists, we have political scientists, and all contribute to how the model was developed to calibrate, in the more precise way, what we would like to show. And this is, I don't know if I respond to your question.
No, I think you did. I'm just interested in some additional takes on this. And I guess I can't help, Siang, but read your paper and think, does it really matter? We do all of this modeling, and as you say, the interventions are similar, and the primary determinant is something that is not typically in the models. So I don't know if you want to expand on that question, on that reaction.
Yeah, in a combination response to what you just said, as well as your earlier question, is there a point to including all of these things in the model? Yes, as long as we're clear about what is going into the model and what the purpose of the model is. By analogy, weather forecast models and global climate models are very different things, but they both have their role. And so it's important, as long as we know, what is the point of what, the model that we're looking at, and therefore what should or shouldn't we include in it. And I think it's important, what we've seen today is that it's important to have a wide range, a diversity of models that address different aspects of the problem. And to your more recent comment, we wouldn't have been able to understand that this responsiveness factor is so critical if we hadn't tried to include that behavioral response in the model in the first place, right? So is there still a role for building a model? Yes, absolutely there is, again, as long as it's fit for purpose.
Very good. I do want to bring in a couple of questions from the audience. Some are a little, one's quite narrow, but I'll ask it quickly also, since Siang, you just spoke. Will you look at responsiveness in relation to long COVID?
I'm not entirely sure what you mean by that, I'm afraid.
Well, I'm reading a question that was submitted by the audience, but I assume it has something to do with as you mentioned, the timing mattering maybe that also could potentially be relevant to the occurrence or consequences of long COVID. But I'm not.
I think to take a quick stab at it, with something like long COVID, where essentially the problem there is that we see consequences long delayed after the cause, right? Long-term consequences, and that's very hard to deal with.
Oh, I believe we've lost you, and now you're moving again. So I'm hoping.
Sorry. Basically, delays make it hard to respond appropriately. Short version.
Sorry
in
about
in our case, Alan, the same, because we analyze trade-offs. So short-term trade-offs. So it's very difficult to answer that question.
Fair enough point. And a question about, well, I'm going to generalize the question around sort of health system functioning. Are there broader barriers around health system capacity and functioning that perhaps we could have or should have known in advance that would have affected the response? And some of this came out, Pedro and Cristian, in your papers, but I'm again going to sort of broaden out the question. What elements of health system capacity are most important for preparation purposes? Anyone want to respond?
I can take that one, Alan. Thank you. No, very quickly. I mean, the feature of resilience, which means be able to prevent, prepare, response, and adapt to emergencies, was not high or very high in the agenda of health systems, to be really honest. The agenda was universal, and is still super important, of course. Universal health coverage, including equity, financial protection, quality, all very important. But the agenda for resilience was not super developed, and was not, and it was mostly focused in the epidemiologic side, which is good, but it wasn't enough. So all the preparation in ministries of health and the studies was around to be prepared, and at least having some basics for example, influenza. There was a big task force for pandemic influenza preparedness, but it wasn't enough, that's for sure. And now we have other threats, other risks that are coming from climate change, from demographic shocks, from conflict and violence, and so on. So that there are other types of risks that will affect health systems for sure. And resilience needs to broaden that focus, and that's the new function that the health system needs to develop with priority. And we are saying here that this has to start from primary healthcare towards the whole health system. That's a focus that we are also proposing now.
A question just came in that actually reflects back, Mark, on I think the first sort of finding that you put up, which is that the next pandemic will be different. So we are very good at looking backwards and saying this is what we got wrong and this is what we should do better. But then the question is, we're probably better prepared if we do all of those things for the next COVID. But if the next if the next pandemic is not, as you mentioned, it could be not a lot of things that COVID was, airborne, and the like. Are the models that you examined and others interacted with able to quickly look at other kinds of potential pandemics, or do we basically start not literally from scratch, obviously, but from a very low baseline of knowledge when something comes that, let's say, is not an airborne, for example, doesn't have airborne transmission?
Yeah, great question. think this isn't just simply a question about modeling, but the sort of wider infrastructure that was modeling and really policy making, which includes the sort of surveillance, the kind of like public health messaging that goes out. And I don't think there's anything inherently technical that says, and if it's not a sort of like airborne respiratory disease like a coronavirus, then the techniques don't exist. I mean, in modeling, in surveillance, in understanding what are the right measures to do. I mean, we've learned from, for instance, HIV, the HIV pandemic. We've learned from Ebola in West Africa. I think there's just a danger that we shouldn't get our system so sort of firmly locked in one direction, that even though we might have the capacity to deal with other sort of like pandemics due to other forms of diseases, we just get locked into one path. And I think that's why, for instance, CEPI, the coalition that is trying to make vaccines for diseases with pandemic potential, is making a whole range of diseases, ranging from respiratory to sort of viral hemorrhagic to STIs, to what it calls disease X, which is something that maybe nobody really knows what it is. And I think that keeping that flexibility in the modeling world and in all these other areas that contribute to pandemic preparedness is going to be really important.
I'm going to take another audience question and turn it slightly. When we talk about topics as a research, as an outlet for research, people often talk about data and data availability and data limitations. So I'm going to ask this question in a certain way, which is, as you think about the challenges you are facing, is there some type of data that you wished you had that you look back and say, if we'd really understood this, and I'm not talking here clinically, like if we had understood transmission mechanisms earlier, but from an analytic or from a modeling or from a policy perspective, is there something in your work that you sort of came across and thought, this is something knowable that we didn't know, and next time we should make sure we have it? Any thoughts on that?
Well, let me say that I think that Pedro Bernal presented something about the consequences of, for instance, prevention and control of NCDs. We didn't have that data at the time. I mean, the policymakers made the decisions. I mean, the calibration, and the consequences in excess mortality, for instance, we're going to see it. I mean, we are seeing now, and probably in the next few years in advance ahead. So that was something that I will, I mean, if I finished my term as Minister of Health in my country just right before the pandemic. So, I mean, I was a bit lucky. But if I had been, Minister of Health, I would have liked to see, the whole picture of the measures. For instance, the policy measures, the mobility restriction, the whole picture of consequences. And I think that we're going to get better prepared for the next pandemic. But of course, we have to work. Not only the health community, at a global level, we have to work.
Okay, well, Pedro, did you want to?
Just adding something to what Adolfo was saying is that at least what we find in our study is that if you see we study everything until 2021, and that's because many of the data that we actually use for this comes with substantial lags. It's publicly available until a year later. And actually probably higher frequency data of what's going on in terms of healthcare use would probably be very useful as well to inform the modeling and just more broadly the understanding of the consequences of the different measures that are being taken in terms of that. So I think that's a really important area to improve on.
That's very helpful. Okay, well, with that, I'm going to thank this excellent panel. I appreciate your papers and your presentations, a nice discussion of everything from small issues to the larger theoretical issues around modeling. It's been great having you. And at this point,